not a popular subject, and residents generally receive no formal training. Unfortunately, this knowledge is necessary to judge the quality of published information. At the conclusion, you should be able to evaluate these objectives. General statistical knowledge is poor. The odds of a DNA match to another individual was 1 in 57 billion. The jury considered this a reasonable doubt. The good news: less than 50% of articles in radiology use statistics, and most use basic, easily understood tests. The bad news: statistical flaws are common. Of 20 tests used in this issue of radiology, 1/3 were used incorrectly. Most readers look for a p-value of less than 0.05 and assume that the results are valid. This is as naive as believing in the Good Housekeeping seal of approval. These are some of the typical flaws. Especially common are t-tests used for ordinal data and using a correlation coefficient as a test of agreement. Analysis begins with data. There are 3 types. Interval data is quantitative and can be measured on a well-known scale. Nominal and ordinal data are qualitative. Nominal is a named category like type of cancer. In ordinal data, the categories are related in a subjective way. For example, heart size judged as mild, moderate, or severe, or cancer stages 1 through 4. There is no mathematical relationship in ordinal data. That is, a stage 2 lung cancer is not twice as bad as a stage 1 lung cancer. Journal articles must be read selectively and skeptically. With the passage of time, these articles seem amusing. 30 years from now, the current literature will be just as amusing. This is a simple method with which to analyze articles. At the completion of any article, you should be able to answer these questions. If you cannot, something is amiss. The second question, what they did, refers to the methods and statistical tests that the authors used. For this question, ask the following, especially, what's the data? For an example, let's review a series of papers which appeared in Radiology. The authors' names have been deliberately blurred. The article's data is summarized in this table. Now ask yourself, what does the number 1.67 plus or minus 0.90 really mean? These authors wanted to find out which method was best to detect pneumothorax. This is an important question. They used 2 different radiographic techniques, traditional film screen and computed radiography, in 3 different positions, supine, decubitus, and upright. The subjects were 3 cadavers in which quantitated aliquots of air were injected into the pleural space. 5 radiologists read all of the films. A sophisticated statistical test, ANOVA, or analysis of variance, was used to test for differences between the radiographic techniques and positions. The radiologists interpreting the films used this 5-point ordinal scale. What did they conclude? First, there was no difference between film screen and computed radiography. Second, the best technique to detect pneumothorax was the lateral decubitus position. Because the mean score for the decubitus film was 4.93, which was significantly different than the mean score for the erect film of 3.0 with a p-value of less than 0.001. A study directly rebutting the previous article was subsequently published. These authors performed a similar study, analyzing the different positions in a group of patients suspected of having a pneumothorax. These authors used the same ordinal scale to score each radiograph. Note the statement for the statistical test used. We will return to this later. Finally, they came to the opposite conclusion, that the erect position was better than the decubitous position. In this example, common to radiology, two tests or procedures are compared. In this type of study, the authors don't know which test is better. It could be either. This then requires a two-tailed test. The tail describes the ends of the normal curve. Rarely, in fact virtually never, is a one-tailed test appropriate. The comparison of two groups is common. Let's look at one of the flaws typically found in testing two groups. The most common test applied to two groups is the t-test. It is the most often misused test in statistical analysis. 2 points. It must be applied to interval data, and it can be applied only to the special case of two groups. Add a third comparison, and the t-test is not appropriate. Now let's return to our example. The original authors wrote a rebuttal, highlighting the statistical flaws in the devil advocate study. They rightly noted that a one-tailed test is inappropriate. The authors emphasized that data must be evaluated with the appropriate statistical tests. Because the rebuttal was evaluated inappropriately, their results stand uncontested and the lateral decubitous position is better. The second group rose to the challenge. Please make note that they consulted with two outside statisticians, and think about that for a moment. Note also that they recalculated their sample mean of their data, 3.631578, a result to a millionth degree of precision. Statistically, it's much easier to get a significant result with a one-tailed test than a two-tailed test. So when reanalyzed with the proper statistical analysis, meaning a two-tailed test, these authors found no difference between the upright and decubitous position. Remember the two statisticians? My guess is that they used two because the first one didn't give them the answer that they wanted to hear. Both groups used this ordinal scale. This is a very common flaw in the radiologic literature, converting ordinal data to an interval scale. This is done so that means and standard deviations can be calculated and common statistical tests like the t-test used for analysis. It is a mistake. Early on, I asked you to examine the original data table and figure out what a mean of 1.67 meant. Here's the reason. There is nothing wrong with ordinal data. Various tests can be used. For further information, choose the proper test for more information. Ordinal data is extremely common, especially in radiology. Sometimes interpretations are reduced to only two choices, like, is there a pneumothorax, yes or no? This does not reflect the subtleties of radiographic interpretation in which gray zones, i.e., equivocal interpretations, are common. Binary data is usually analyzed with statistics such as sensitivity and specificity. The calculation of this accuracy matrix can be found by selecting binary data. Beware of small numbers. Half of the articles in radiology deal with less than 30 subjects. For example, consider the study of SPECT in identifying hemangiomas in cirrhotic patients. The authors only reported sensitivity and specificity without confidence intervals. You can calculate the confidence interval from their data by using the calculator. Just click on Binary Data. The wide confidence interval stems from the small sample size. It reminds me of the story of the medical student at a research seminar presenting the results of his study of a drug on rats. 33% of the rats died, 33% lived, and the other one ran away. Remember, proportions can be very misleading. A common innocuous statement in research reports: disagreement was resolved by consensus. Disagreement is a valuable parameter and really reflects the reliability of a test as it is applied in practice. Most often, consensus really means everyone caves into the boss. There are two common flaws in judging agreement. One is using the statistic percent agreement, and the second is using the statistic correlation coefficient. Both are misleading. The proper statistical test is kappa and can be calculated by clicking on the button. Most problems arise because of the data. If the author has used the t-test, remember that it requires interval data and only two groups. In analyzing proportions, remember sample size. And finally, agreement between observers requires kappa. Thank you very much for stopping by.